previous published reports, it it is present in about 8 to 20% of these patients. And in our study, we got 15.4%, that is 11 of 71 patients. We identified 2 risk factors for having a positive gammagraphy for an accessory spleen. The first one was a complete response to corticosteroid therapy as first-line treatment. And the second one was, in fact, a protective risk factor with an OR of 0.088 that was having the presence of Howell Jolly bodies in the peripheral blood smear. So we developed a risk score. And in this risk score, we had patients with 1, 2, or none of these risk factors. The risk factors being the complete response to corticosteroid therapy at first-line treatment, and also the absence of Howell Jolly bodies in the peripheral blood smear. And by doing this, we could identify that the population with 2 risk factors are at most risk of having this gammography positive. So it was useful because you can try to know beforehand in which patients you can use a gammography to see if there is an accessory spleen. Of the 11 patients with an accessory spleen, 8 underwent accessory splenectomy. We had an overall response rate of 100%. All but 1 had complete responses. The patient that had a partial response also continued with absence of Howell Jolly bodies in the peripheral blood smear. In 6 weeks later, he relapsed. So he had a new gammography. He was diagnosed with a new accessory spleen. He had a second accessory splenectomy, and then he got a complete response and presence of Howell Jolly bodies. So this treatment is effective, or was effective, in our population. And also no patient had any complication. So it's very safe. I think the biggest limitation is that our study is retrospective. So we would want to see if these results stand in a prospective trial. Also, I think that our population, because of economic reasons, can't get rituximab or eltrombopag, which are medications that are proven to be very good second-line treatment medications for immune thrombocytopenias. So maybe it has to be done also in population who already received rituximab or eltrombopag. And finally, I think that for a developing country, it is a very good strategy to be put in place because it's much cheaper than trying to give one of the newer medications.